I'm introducing, it's great pleasure to introduce Dr. Parvesh Valiabh, who is working as an acute inpatient psychiatrist at Surrey Memorial Hospital and chronic pain management clinic at Jim Peterson Outpatient Clinic in Surrey. He completed his family medicine training from South Africa and psychiatry training from University of Alberta. He's going to talk about biopsychosocial approach in chronic pain management. So, Dr. Valiabh.
So I'm a general psychiatrist, but I have an interest in chronic pain. Many of you may have treated some patients with chronic pain, and by the time they come to me, they've gone through quite a bit of brilliant people. So when they come to me, they're hoping to have answers, and sometimes I'm really struggling to have answers. So I describe myself to them as the person at the bottom of the totem pole. I said, you've been through everybody, so now I'm the bottom of the totem pole. I don't have any disclosures. The objectives have been sent, and this was to understand the pathophysiology of chronic pain, implement some psychological strategies in chronic pain, and apply practical techniques in treating patients with chronic pain. As you know, I'm a psychiatrist, so this presentation will be biased more in a psychiatric manner. What is the definition of chronic pain? The International Association for the Study of Chronic Pain initially came up with stating that it's an unpleasant sensory and an emotional experience associated with actual or potential tissue damage, or described in terms of tissue damage, or both. In 2020, they refined and adjusted this, and they've actually taken away the last bit, which is described in terms of tissue damage or both. My slides, unfortunately, didn't update, but why I'm mentioning that is because originally they were biased towards people describing their chronic pain verbally. So in 2020, they realized that not everybody can be verbal and vocal about their pain. So they decided to change and drop that, where they don't have that anymore, where it's described in terms of tissue damage. The other aspect is they've also changed and they've added something where it says associated with actual or potential tissue damage. Now they're saying associated or resembles actual or potential tissue damage, which means that there may not necessarily need to be tissue damage for there to be chronic pain. The other aspect is chronic pain, by definition, by the International Association for the Study of Pain, have defined it as being something that lasts more than 3 months. So when a pain syndrome is lasting more than 3 months, it becomes a chronic pain syndrome. Interestingly enough, in psychiatry, if you look at the origins of how pain was described initially, Plato and Aristotle in the Greek philosophies described it as emotional pain of the soul. And they said no matter where you have pain, whether it's in your leg or anywhere, it eventually lands in your heart. So they were quite philosophical, but said it was an emotional pain. It was a pain that was affecting one's soul. Then there was René Descartes, who eventually came up with this mind-body dualism. So he described that pain was actually either from your leg or your arm, from the periphery or the brain. So he decided to separate it and created this what we call a mind-body dualism. And for many of us over here, when we were trained in medicine, if you were not able to see pathology, it didn't exist. And you'd be like, well, there's nothing there. So what do I treat? So that was where Descartes came from. And ultimately, over the years, we have a few other people that have actually come around, and they've described other theories of pain. And this is what I'm going to be talking about today as well. Chronic pain is one of the leading causes of disability worldwide. It's almost a third to 50% of the people in developed countries report moderately severe pain, or pain that persists for more than 6 months. The Center of Disease Control analysis from the National Health Interview Survey estimates about 21% of adults in the US and had chronic pain, and about 7% had impact or had a severe impact or high impact on chronic pain. So this is something that's persisting. It's not going away. Even if we want to turn a blind eye, I've realized that you can't. They will still keep coming. They will still present to your rooms. So what do we do? This is a picture in, I think, if I remember correctly, it's in Honolulu. It's a maze, and it's the pineapple plantation. Sometimes when I have a patient, I think this is where we're at. We're in a maze, the chronic pain, because where do we start? Where do we end? We don't have any real guide. The patient has been to neurologists, maybe even surgeons, anesthesiologists, and now they're sitting in front of me and where do I go? So a treatment plan, and as I mentioned, being biased that this is a psychiatric approach, over the years, when I had been working in a chronic pain clinic in the University of Alberta, I realized that I was treating patients that all eminent specialists have treated. By the time they came to me, I had to have some kind of approach. So I realized that after working with one of my master's supervisor, who was actually brilliant in how he formulated pain, came up with some theories of how we could help the patient. So in the clinic, we realized we needed to look at a multidisciplinary approach. And one of the models that he kept referencing was the gate control theory of pain. I'm not sure if this was something that I kind of stumbled upon in my training during psychiatry as well as with chronic pain. And it was by Ron Malzak and Wall. And these two gentlemen basically in the 1970s described how pain is perceived in our brain. But there's two different pathways. So there's a pathway where we have a slower pathway where pain is actually conducted. Now, I'm not a neurologist, so I may be butchering some of this explanation, but I'm going to give you my interpretation of this because it did help make sense for me. So you have a slower pathway, and then you have something that actually can inhibit that pathway. And so this is the best way I describe it to patients, and maybe I'll explain to yourselves. If we have pain, and it's chronic pain, and we have stress, we are exacerbating that pain. If we have pain and we calm the stress in our lives, we might reduce the pain. So this is kind of the theory. But interestingly, in the 1970s, there were patients that were having pain syndromes, intractable angina, and they were wondering, how do they treat these patients? Because there was nothing more they could do. This is where the spinal cord stimulator came in. So the spinal cord stimulator was actually doing, in theory, this particular mechanism, that you have a pain pathway, but you have an alternative pathway where you're trying to activate and do an inhibition to the pain pathway so that the pain is not actually as expansive in the brain or perceived in that manner. It's down-regulating that pain perception, if that makes sense. Then there was another individual by the name of Engel who came up with this biopsychosocial model. And interestingly enough, this is what resonates with us in psychiatry. We treat our patients with the biopsychosocial model, and we're always targeting all the different facets in our treatment plan, but more so in chronic pain, because you'll find that you actually have to look at all of these things. And then I used this kind of hybrid approach with a biopsychosocial model, with this gate theory, and try to actually help patients. Now, lately, with the Royal College and even with the residents in Canada, and I'm sure abroad, there's this wave to now say biopsychosocial spiritual model. So we're actually looking at it as a multifaceted approach. I've gone a little further and said biopsychosocial spiritual cultural model as well. So the gate theory, as mentioned, was coined in 1965 as a way to explain how non-painful stimuli can reach the brain faster than painful ones, and that a gate control system modulates the sensory input from the skin before it evokes pain perception and response. So in our approach today, which I will be describing, is how to close these gates. They may not necessarily shut the pain down. And I tell patients this, that when you are seeing me, I'm not going to be able to take your pain away. As I mentioned, you've seen a lot of bright people, you've seen a lot of people that were trained in various facets of medicine, and they couldn't help. But what we're going to do is improve the quality of your life. So if I can downgrade your pain from a 10 to maybe an 8 or a 7, that's what we're doing with the intention to improve the quality of your life using these principles. I highlighted this, the biopsychosocial model. George Engel in the 70s again. He suggested that to understand a person's medical condition is not simply the biological factors to consider, but also the psychological and the social. This is the overarching framework that most pain clinics use. They actually have a multidisciplinary team. There's pharmacological components, there's intervention components, then there's the psychosocial components, and there's even some lately more research being done in the social aspects, and I'll come to that later on. If we look at the brain actually in chronic pain is activated in multiple areas. Like in the healthy brain, you'll probably just have the somatosensory area affected. But in the chronic pain brain, you'll have the anterior cingulate, you'll have the amygdala, you'll have multiple areas that are highlighted. And I'm not going to go into all details, and I know I pressed for time, so I'm going to make sure I try to get through this as quick as I can, making sense of what I'm saying. So the treatment options, as I mentioned, the biopsychosocial, obviously medication, then we look at psychotherapy and the social aspects. And the new research that's coming is actually on stigma in chronic pain. What to avoid? I'm not a guru in the narcotic world. My anesthetic colleagues target patients and treat them with these interventions when others have failed. But I'm actually a bit leery of recommending all of this because the latest guidelines are trying to avoid opioids. So again, what are the other options? A lot of patients that come to see me are anxious or depressed. They are always looking for a diagnosis, which obviously I can't give them for their pain, but I could actually look at the comorbidities. For major depression, we have treatment. For the anxiety, we have treatment. So looking at what we have, the biological treatments in the anti-epileptic world, we have pregabalin, which is indicated for fibromyalgia, diabetic neuropathy, and seizures. It is in up-to-date described as being off-label for generalized anxiety disorder, but you'll find a lot of these patients are really anxious. So if you had to have an anxious chronic pain individual who has a comorbid neuropathy or fibromyalgia, I think it would make sense to use that medication because you'll target both things, the anxiety as well as the pain syndrome. This is going back from the pain gate model, that if you dial down the anxiety, you might actually even also effectively help the pain syndrome. Lamotrigine is also interesting. It's used in bipolar depression. It is used, interestingly, by my anesthetic colleagues off-label sometimes for some migraines, which I was pleasantly surprised to see. But I find it also helpful in those individuals that are quite depressed and quite labile. And this is an area in psychiatry also we are evolving, which is the mixed episodes of bipolar depression. Mixed episodes of bipolar illness. You find these patients are very difficult to treat, but lamotrigine may have some benefit over there. Obviously watching for skin rash, because the Stevens-Johnson syndrome, and watching for the tolerability, and going slow with the titration. Gabapentin, obviously used quite a bit. It's used for post-hepatic neuralgia and in focal seizures, as mentioned. Off-label, it's used for alcohol use and neuropathic pain. It's very commonly used because I'm not sure where everybody practices, but in BC and in other provinces, sometimes Lyrica or pregabalin is not covered. So then we're stuck. So then we end up using gabapentin instead. It's not, interestingly enough, having the support or the evidence for anxiety as pregabalin. So I do prefer it. Prefer pregabalin over gabapentin for that reason, from a psychiatric perspective. The antidepressants, duloxetine, everybody probably has heard of that. It's used, interestingly enough, in pain syndromes and depression. Other SNRIs, again, when duloxetine is not covered, we end up using venlafaxine. There's a typo. I got milnacipran, but that's not available here. We have levomilnacipran, and interestingly, that's only indicated for depression. But milnacipran is indicated for fibromyalgia abroad. So in other countries, it is used. But I've not got much experience in that, so I'm not going to try to tell you how that works. Tricyclics, you've heard of that, nortriptyline, amitriptyline, they are being used for pain syndromes. I'm always leery a little bit in the chronic, destitute, desperate patient because patients will tell me one didn't work, and sometimes they don't tell you, but they might take two or they might take three. And that's when they can run into trouble with a tricyclic antidepressant. So I'm a bit more, I would use a shy prescribing this to them. The atypical antipsychotics, you've heard of these, brexpiprazole, aripiprazole. These are used as adjuncts for major depression. Now, a lot of these patients, by the time they see us, are depressed, they're anxious, they don't basically trust people, and they are either on one antidepressant, maybe duloxetine, maybe another one. So we add this, and I find that this also downregulates the brain in calming them if they can tolerate. Obviously, they have to watch out for the side effects. There's metabolic side effects, anxiety and restlessness that can occur with aripiprazole or in the beginning stages. But the other aspect is gambling. I always counsel them that there is also that potential. And the other trick behind chronic pain patients generally is start low and go slow. So use the lowest dose and don't rush it. I actually even start with 1 milligram aripiprazole and leave it for about 2 to 4 weeks before I even go to 2 milligrams, because the tolerability can be a real challenge in these individuals. Quetiapine XR is also used as an adjunct, but as mentioned, monitor for EPS, metabolic side effects, and the QTC interval. Now moving to the psychological components. You'll find here there's a lot of evidence behind cognitive behavior therapy, MBSRT, and ACT. These are the new and validated ones, and they're used for chronic pain. In the mainstream, CBT is found almost everywhere. But what's interestingly enough, when I see patients, if you tell them go for CBT at the local mental health clinic, they're going to end up sitting with people with depression and anxiety. And the challenge is they'll drop out of treatment because people don't understand it. So you're best served by sending them to a CBT, which is pain focused. And if they have insurance that can cover that, that'll even be beneficial. So I find when it's tailored, it's even better. Basically, the treatment, we had the comorbid illnesses, PTSD, major depressive disorder, generalized anxiety disorder. And if there's personality issues, then obviously treating that comorbidity, and with substance use, the same. I will conclude with this because this is the new field that's coming up, and that's this emerging studies on stigma and chronic pain. I don't know about you, but a lot of patients, by the time they've reached that chronic pain syndrome state where they're not getting help, they basically feel frustrated and feel like they're being attacked, and they're on the defense from the get-go. They're either angry or they're sitting there with their backs up and saying, you don't trust me. And that's coming down to stigma. So what's interesting is there's been a latest meta-analysis which shows that there's a positive correlation between stigma, pain intensity, disability, and depression. In my master's, I actually did the stigma scale study with my master's supervisor, and this was about a decade ago, and now this has come out. What was interesting is at that time we noticed that there was a decrease in how families and patients perceived doctors when they went to CBT groups together. We had 3 groups. We had a group where the patient was coming on their own, 2 when they came with family, and 3 basically was a placebo group, which means there was this supportive therapy. But we found evidence where if individuals came with their family with CBT, the stigma improved. Now, the latest meta-analysis reported that stigma during the ACT and cognitive behavior therapy, we saw that there were changes, and that there's an association between stigma and even disability and pain and depression. But the association between stigma and depression seems to be high. And that if you're able to actually treat these patients or maybe address stigma, you might actually be providing, and this is a theory, some cognitive flexibility in these patients because they can be quite rigid. So if they go through CBT or if they go through these acceptance commitment therapy, you might be working on some flexibility and it could improve outcomes. So I'm going to leave it like that because I'm mindful of the time. But I will say that at the end of the day in psychiatry, our optimism in treating a patient is on a therapeutic alliance. That means how good of a relationship we have with the patient in treating them. So I find that if you follow this model, or at least I have, it has helped me to improve that alliance and even in managing these patients and not getting stressed or even burnt out in the process. Okay, thank you.